Good afternoon. I'd like to welcome you to Certified Community Behavioral Health Clinics. Please allow me to set some ground rules for the session. Your audio and video features will be muted throughout this session. If you have questions or would like to add to the conversation, you're encouraged to use the chat feature. We'll be scanning the chat box throughout the session, and if time permits, we may address questions in the chat box or open questions up for discussion. If you use inappropriate language in the chat box, you will be removed from the conference. The Texas Health and Human Services Commission welcomes dialogue about behavioral health care, as all Texans deserve access to care at the right time and the right place. As the conference host, the Texas Health and Human Services Commission recognizes some panelists participating in this panel are external to the state agency, and some viewpoints or opinions expressed during the session may not reflect the views or opinions of the Texas Health and Human Services system, its agencies, or its staff. And now let's start our session. I'm Jay Todd, and I'll be moderating today's session. I'm Director of IDD Behavioral Health Innovation and Engagement for the Texas Health and Human Services Commission. Joining me today are Melissa Martinez, Behavioral Health Integration Specialist for Texas Health and Human Services Commission, Gianna Harris, Executive Director, Helen Farabee Centers, Andrew Martin, Associate Executive Director for Helen Farabee Centers, Jenny Good, Chief Executive Officer for Betty Hardwick Center, and Dina Heaton, Chief Administrative Officer for Betty Hardwick Center. We're going to start today's session with Melissa Martinez and a brief overview of the Certified Community Behavioral Health Clinic model and the HHSC approach. Melissa.
Great, thank you, Jay. So good afternoon, everyone. Thank you for joining us, and we hope you've had a pleasant virtual conference so far. And if you're just joining us, welcome to the All Texas Access Conference. This session, as Jay said, is the Certified Community Behavioral Health Clinics Initiative. So we're gonna go ahead and jump right in. If I can go to the next slide, please. Great, so to give a brief overview of what to expect during this session, we'll be starting off with a presentation about Certified Community Behavioral Health Clinics, or CCBHCs. This presentation will cover some of the history and basics of CCBHC and provide a brief overview of how CCBHCs are currently operating in Texas. For the second half of this session, we'll have a panel discussion with representatives from two certified clinics, Helen Farabee Centers and Betty Hardwick Centers. If time allows, we'll also have a question and answer session at the end. We ask that as we move through the presentation, go ahead and put your questions in the chat box. And if we have time, the folks that are monitoring the chat box will let us know what questions we can answer. So next slide. So to get started, what is a CCBHC? So CCBHCs were first introduced in the Protecting Access to Medicare Act of 2014, also known as PAMA. As a result of PAMA, the federal government had to establish demonstration programs to improve community behavioral health services. As part of this process, the Substance Abuse and Mental Health Services Administration, or SAMHSA, was tasked with creating and publishing a set of criteria for behavioral health clinics to be able to participate in these demonstration programs. The criteria published by SAMHSA outlined a model of care promoting the integration of mental health, substance use disorder services, and primary care screening. CCBHC represented an opportunity for states to improve the behavioral health of citizens by providing community-based mental health and substance use disorder services, advancing integration of behavioral health in primary care, using evidence-based practices on a more consistent basis, and promoting improved access to high-quality care. So what holds all of these pieces together is care coordination, which is often referred to as the linchpin of CCBHC. Care coordination stresses the importance of ensuring individuals receiving care have their needs and preferences known by the organization, and that those needs and preferences are communicated at the right time to the right people, and that this information is used to provide safe, appropriate, and effective care to the individual. So next slide, please. So to become eligible to be a CCBHC, behavioral health centers had to be providing a certain set of services. So on this slide, we have 9 total services, 4 of which that you'll see on the left side of the slide are services that must be provided directly by a center interested in becoming a CCBHC. So those services include crisis mental health services, screening, assessment, and diagnoses, patient-centered treatment planning, and comprehensive outpatient mental health and substance use services. On the right side of the slide, in the right column, there are 5 services that can be offered through a partnership and also can be offered by the center itself. So those services include outpatient primary care screening and monitoring of key health indicators and health risk, targeted case management, psychiatric rehabilitation services, peer services, and veteran services. For Texas, all of the centers that are currently certified already provide 9 of the required services, but are still expected to work with other organizations that may provide some or all of these services as additional supports. Next slide. All right, so this is a little bit of a busy slide, but in order to coordinate care effectively, CCBHCs are also required to work with other community providers to establish care coordination agreements that outline the expectations for each of the organizations that may be working with the same individual that the CCBHC is working with. Common types of organizations that centers have to work with include federally qualified health clinics, or FQHCs, inpatient treatment providers, schools, juvenile and criminal justice agencies, the Veterans Administration, housing and employment organizations, hospitals, and emergency departments. Through this work, CCBHCs have an impact on other systems as well, which include how we think and talk about other state-run programs such as Medicaid programs, and then also other types of projects such as value-based payment methodologies. And it also promotes the alignment of outcome measures across different areas. Next slide. So in Texas, CCBHC efforts have been ongoing since 2016. 2016 served as a critical year for us as we were tasked with certifying our first centers in alignment with the criteria that had been published by SAMHSA. During this time, we certified a total of 8 sites, one of which includes Helen Farabee centers, which you'll hear from later today. During this period, our 8 sites included 7 mental health authorities and 1 nonprofit organization. The pilot sites were certified as part of a larger grant project, which required an application for the national demonstration phase of the project. Texas was not awarded as a national demonstration state. However, the pilot sites continue to work on operationalizing elements of the CCBHC model, and Health and Human Services continue to refine process for certification and began looking at expanding the use of the CCBHC model with other sites during 2017 and 2018. Just last year, Texas increased the total number of CCBHCs from 8 to 12 and put in place a process for continued rollout of the model. With the support of the inaugural Health and Human Services business plan, the Texas CCBHC team continued to work on expanding the number of CCBHCs, ultimately increasing the number of certified sites to 21, with additional sites planned for certification in 2021. Currently, about 70% of the Texas population lives in a county that is served by a CCBHC. Next slide, please. So I do want to go over briefly the certification process for CCBHC. CCBHCs do go through an extensive process for certification, and I think some of the centers on our panel today will be able to attest to that. But we've gone ahead and summed up the certification process into 3 big steps, which you'll see on the slide. To start off the process, all centers have to submit a CCBHC application form that asks about current services, evidence-based practices, partnerships, and capabilities of electronic health records. Once the center is accepted into the certification process, we begin a desk review of all relevant policies, procedures, and supporting documentation that align with the CCBHC criteria. The CCBHC criteria consists of over 150 different elements across 6 different key program requirements, which Health and Human Services, and specifically the Texas CCBHC team, is tasked with scoring for each center. On average, sites take about 4 to 5 months for their certification reviews. We have multiple tools we use at the state level for these assessments, which we won't go into today, but once a center completes the desk review portion, the Texas CCBHC team conducts interviews with staff from the center to gain an understanding of how CCBHC has been communicated and adopted by the center. Certification lasts for about 3 years, and depending on how long since the initial certification, the recertification process can include a targeted or full review of the center. Next slide, please. So in transitioning to become a CCBHC, centers often have to revise their policies and procedures to better align with the CCBHC criteria. Throughout our work with the centers, we've seen how different centers have used different tools for educating their staff about the model and the changes occurring as the center works towards becoming certified. This year, we've seen innovative approaches with virtual scavenger hunts, CCBHC University, and CCBHC ambassador programs that are implemented across the centers. When a center does achieve a certification, they receive a copy of our Texas CCBHC seal, which you'll see in the middle and then also on the big banner. And this indicates that they have met all of the requirements to be recognized as a CCBHC in the state of Texas. As you can see above, achieving certification is also cause for some celebration, as the centers can often spend years preparing for CCBHC before they even apply. Okay, next slide. So although CCBHC continues to evolve in Texas, our guiding principle has always stayed the same. So if you can't remember anything else from this presentation, please remember that what moves us and CCBHCs forward is the guiding principle that for us, CCBHCs are built on a philosophy that emphasizes consistent quality, care coordination, and the best outcomes for our clients that receive behavioral health services. Next slide. So as we reach the end of this presentation, I want to touch on a few of the things our team is working on for the future of CCBHC. In addition to the continual refinement of certification tools and practices, we're also pulling different resources together to support our evaluation efforts. Currently, we are looking at how CCBHCs are performing at a state level, but hope to be more focused on individual clinics as well as we move forward. One key accomplishment that we have seen so far as part of the CCBHC project is the elimination of waitlists for adult services for sites certified as a CCBHC. Early data also indicates significant increases in adult functional improvement. And as we continue our evaluation efforts and have more data available from newer CCBHCs, we anticipate having a more formalized evaluation report available. As mentioned earlier in the presentation, we are also continuing with our certification efforts. With additional centers in line to become certified next year, we are currently prioritizing local mental health authorities, but we do plan to open this process up to other organizations such as nonprofits and local health departments that meet the requirements that we touched on earlier in the presentation. So from a funding perspective, because I know that that's always a question, most of the work that we have done so far has not been funded. However, centers that have been certified as a CCBHC have been able to apply for some recent SAMHSA opportunities, with the most recent being the CCBHC expansion grants that were primarily focused on providing funding for centers that have been certified as CCBHCs in states that were not selected as part of the national demonstration. By moving forward with the integration of behavioral and physical health care, CCBHCs are also positioned to be potential awardees for future federal grants. Another aspect of CCBHC that occurs specifically at the state level are efforts around alternative payment methodologies that allow for CCBHCs to work with their managed care organizations to receive quality-based payments. Moving forward, we expect that more CCBHCs will be engaging in these types of arrangements to support the added requirements and benefits of providing care coordination to clients. Okay, next slide. So that is the conclusion of this presentation. I just wanted to give a shout out to the Texas CCBHC team, because even though we are small right now, we are very mighty. And we do have a Texas CCBHC Initiative inbox. So if there are questions that you have after this presentation, can definitely email that inbox. This presentation is recorded, so it will be available online as well. So I think with that, I'll go ahead and hand it back over to Jay.
Thank you so much, Melissa. So yeah, so with that overview, I'd like to go ahead and bring our other panelists in and move the discussion to the impact of CCBHCs within a rural community. As Melissa mentioned, Helen Farabee Centers is one of our original CCBHCs, and Betty Hardwick Center is one of our newest centers. And before we start talking about the impact that CCBHCs have had on the centers, I'd like to hear a little bit and get them to share with you about the centers. So Gianna, could you tell us a little bit about Helen Farabee Centers?
Certainly, thank you, Jay. Serving North Texas since 1969, Helen Farabee Center operates more than 20 program sites within our 19-county catchment area, which spans more than 16,655 square miles. Helen Farabee Center specializes in providing access to community-based treatment and support for persons with severe and persistent forms of mental illness, substance abuse, intellectual and developmental disabilities, and early childhood issues. Employing 281 staff, our center provides behavioral health and developmental disability services for more than 10,000 Texas citizens monthly, and in many cases, their families as well. Helen Farabee Centers was originally designated as a certified community behavioral health center in 2016 and was recertified as a certified community behavioral health clinic in 2019. While our center serves a large population over a very broad geographic area, we are dedicated to knowing and meeting the needs of people who come to us for help, as well as the communities we're here to serve. And I'm very honored to be here today, and thank you for inviting us. And thank you everyone for participating. So thank you.
Thank you a lot. So Jenny, I want to ask you the same thing about Betty Hardwick Center.
Okay, sure. Betty Hardwick Center serves residents of Taylor, Jones, Callahan, Shackelford, and Stevens counties here in the northwest part of Texas. We provide early childhood intervention services and services to people with intellectual disabilities and behavioral health conditions. The total population for our service area is a little over 183,000 people, which covers about 4,500 square miles. Of course, about 74% of that population is all here in Taylor County, which is where Abilene is. And so our other 4 counties are considered pretty rural. The service area is home to Dyess Air Force Base, and we have 3 universities and 2 colleges. And so we have a really dynamic population of people moving in and out often. We have pretty limited access to psychiatry services or any private behavioral health services outside of what the center offers. There are some services, but it's a pretty small number. And so as a result of that, the center often is looked to help find solutions for not only here in Abilene, but certainly in the rural areas that surround us. We have about 200 employees. We serve about 8,500 clients a year in a variety of services. We became certified as a CCBHC center in May of 2020. So it's still a relatively new situation for us, but we are happy to be here today.
That's great. Thanks so much for being here. As Jenny mentioned, the certification for Betty Hardwick is fairly new. And I wanted to ask Dina, when Betty Hardwick was looking at CCBHC certification, what was it that you were hoping to improve or achieve or move towards by becoming a CCBHC?
Well, the CCBHC model allows you to look at the whole person and better serve the client needs. You know, We it also helped us think about more strategically about the policy and procedures that we had, our local needs assessment and our staffing needs and priorities, and even our community partnerships. You know, we recognize that we have gaps and weaknesses, and some of those have been addressed and some of those are still in the work in progress. And that's even a benefit in itself because it helps us keep focused on our work. You know, there's gaps in care, fragmented care, and uncoordinated care. All those linked to high utilization of the ER and acute admissions. You know, persons with behavioral health conditions may die decades earlier than the average person, and most of those are because of untreated and preventable chronic illnesses like hypertension, diabetes, obesity, and cardiovascular disease. And I believe that care coordination and quality metrics that focus on health of the clients can impact this.
That's great, thank you. As one of our kind of original CCBHCs, Andrew, what are some of the benefits that you've seen since becoming a CCBHC for Helen Farabee?
To find the mute button, sorry. Well, for sure, being a CCBHC results in a lot of care improvements for clients, but becoming a CCBHC was a valuable process for the organization. The certification process itself helped us evaluate our practices and revise the tools that we use to deliver care. We had to look hard at our procedures, various assessments, and tweak those to meet standards. Two main benefits we continue to see are first, participating in federal SAMHSA expansion grants. The Texas version of CCBHC certification is not far off from the federal standards. So having been certified in Texas initially, we were able to apply for the SAMHSA expansion grant without having to do a lot of prep work towards certification. And now we are in our second 2-year federal grant period, and that money is currently sustaining several major initiatives that we started through the 1115 waiver. Outpatient substance abuse services, psychiatric open access, and developing, implementing a care coordination unit, and then continuing our peer services. Another benefit is the emphasis we put now on physical health monitoring and interventions. We added to meet certifications several targeted health screenings and follow up on those screenings through immediate education, some counseling, or through referrals. We added care coordinators who take that health data and identify at-risk clients and help them to connect to primary caregivers in their area.
That's great. Dina, I know that you had mentioned that there were some definite things like care coordination and quality metrics that you started focusing on there at Betty Hardwick. And this, you know, Dina or Jenny, what are some other things that becoming a CCBHC caused you to focus on?
Well, to become certified, the center has to indicate that they have involved consumers in a meaningful way in the governing bodies. And we have had an advisory committee for some time here, but it led us to reevaluate those. You know, centers have used evidence-based practices, but the certification process requires a diligent knowledge and application of the evidence-based practices. You know, we must be committed to cultural competency and person and family centered care, and administratively commit to continuous quality improvement.
Great, thank you. You know, part of this conference today is All Texas Access, and there's a strong focus on rural resources and those connections. one of the hallmarks of CCBHCs is, as Melissa said, the linchpin is care coordination. And I was wondering, either Jana or Andrew, from a Helen Farabee perspective, how might care coordination look different in a rural community?
I'll start with this one. We've used our care coordination unit to help address a lot of the disparities that we see in a rural service area compared to a more urban one. And I want to just give you a brief picture of what that unit looks like at our center. We have a team lead, an administrative assistant, and 4 care coordinators. Those coordinators complete care coordination assessments for all clients every 90 days and respond to any health indicator issues that they see in those assessments. They examine our health data for health risk indicators and make contacts when appropriate. They help with the referral and access to primary care, and they retain complex cases on their own caseloads. Those would be clients who have a behavioral health issue, but also complicated primary health issues. We currently have about 400 enrolled in care coordination across a 3-tier service system, and that amounts to about 12% of our adult population. Our care coordinators tend to do the most work with clients around primary care referrals and helping them to obtain medical equipment. So we serve a rural and even frontier service area, and that creates several health disparities compared to more urban areas. Our unit, care coordination unit, helps address some of those. For example, I'll go through a few of them. Geographic isolation is one. Offering service options for those outside our traditional catchment who experience limited options. Traditionally, we would serve a 19-county catchment area per our contract with the state, but becoming certified means we're ready to serve folks outside of that catchment. And for some, it makes more sense for them to visit our LMHA versus a neighboring LMHA that is actually farther away for them. That's not something we did before, but it's helpful now. We use telehealth a lot, leverage that as much as we can for open access, for our psych evals, for follow-ups. And now since the pandemic, a lot of our services are now gone virtual. Another disparity that we try to impact is a lower socioeconomic status. Folks in our area are more likely to be unemployed, less likely to have post-secondary education, and have lower median household incomes. We've always faced these issues with our populations, but now as a CCBHC, we can help a little bit more by using care coordination to identify comorbid health-related issues and arranging good referrals for those. We have tried to establish care coordination agreements with our FQHC, and they serve a similar low SES population. Another disparity that we look at is higher rate of health risk behaviors like smoking, drinking, obesity, lack of exercise, insufficient sleep, things like that. The care coordination assessments that we do can help us provide education and referral points for those clients. Some physical issues and indicators may not have been formally addressed in that way prior to us being certified. As others mentioned, we have limited access to specialist care in our area, and becoming a certified clinic does not mean that we have suddenly more specialist options in our area, but we can help by screening for health issues and connecting clients to existing resources they wouldn't have access before. Our efforts at establishing more care coordination agreements and MOUs has helped with that. We have healthcare workforce shortages here, and setting up some MOUs and care coordination agreements with other local providers just helps improve some of the efficiencies in accessing care and making referrals, putting less stress on that system. And then finally, we have a lack of reliable transportation in some cases. Our our care coordination team are able to help with transport. At least that was true before the pandemic, and try to help connect people to primary care appointments, would even attend the appointments with them, trying to be an advocate. So those are a few of the disparities we've seen and tried to help out with, in particular, care coordination.
Great, thank you very much. Ginny, I want to ask you, from your perspective as y'all became a CCBHC, how can CCBHC be used to address some of the disparities between rural and urban communities?
I think one of the ways to look at that is that in order to become certified, we all, regardless of where our geographic location are, have to be able to provide evidence that we meet certain criteria as a process of being certified. And so some of the things, so the list of things that we need to be able to do is comparable regardless of where we're located. So Melissa's slides earlier on talked about the list of services that must be provided. We're doing those things, but it also levels the playing field in that it sets a common standard for some other things like timely access to services, not just to the front door services, but also to psychiatry. So regardless of where you're located in Texas, you should be able to achieve a timely appointment for the behavioral health condition that you're being treated for. It also requires us to use evidence-based practices. And so we've always done that, but the certification process causes us to review that a little more closely, more diligently, and make sure that that's available across our service areas. It also, the integrated care aspect, when Betty Hardwick Center began the process to become certified, we were not currently licensed as a substance use treatment center. And so our rural counties had less access to that than might have been available in some urban areas. And so we went through the process to become licensed as a treatment provider again, and therefore substance use services are available in all of our areas, regardless of whether they're rural or urban. And so in that way, even though some things might look different, they may be smaller numbers, there may be fewer community partners to work with in some of those, the same basic level of services and the quality is similar regardless of where we are in Texas.
Great, thank you. So we've got a very active group of people joining us today. And so I wanted to turn to some of the questions that are coming in from the audience. And I'm going to have this one go to Gianna. So can you talk about how the data that's collected from any of the CCBHC measures is used to guide your service delivery improvements?
This may be one that I'm going to bump to Andy more so because he's our data guy and I'm the one that he reports the data to. So I'm going to defer that to him, and I might pick up somewhere else in some of these questions. So
all right.
Yeah, we have some examples of the data that we get are around physical health conditions, smoking, drinking. I see a question there about whether we track diabetes and high blood pressure, and those are some standard screenings that we do for all clients coming in, and we can aggregate that data. They do influence some of the state performance measures that we're being tracked on, but in more real-time care, we're using those numbers in care coordination. A care coordinator will look at a spreadsheet of numbers connected to client names and see things that stand out as maybe being outside normal limits. So we'll contact those clients and get them into the referral that they need. That's one example.
Great. And I'm going to let any of y'all jump in on this one. So we've got a question in terms of the CCBHC case managers or care coordinators, and how do they interact with that patient's case manager from an MCO?
We have several MCOs that we interact with, several different ones, and they will periodically review what's going on with our clients. They will contact us if they see something in the data for a client that they need us to know about, and we'll do the same the other way. But we have, yeah, that's about it.
Well, and to the, as you know, as many people that are LMHAs know and have contracts with MCOs, we are audited by the MCOs on a frequent basis. And so if they see issues, they're talking to us, and then there's a lot of communication back and forth about any sort of issues in that manner as well. So then there's dialogue between the caseworkers or the care coordination units with the MCOs and clearing things up in that manner too with the case managers and the auditors of those MCOs.
Great. So Jenny and Dina, there's a specific question that came in for Betty Hardwick. Could Betty Hardwick's staff discuss some of the ways the center is answering psychiatric needs of people incarcerated in the Taylor County Jail, especially during this pandemic?
Sure, I'd be glad to talk about that. So in our jail, in our 5-county area, we have 2 jail navigator staff. They both work here out of the Taylor County Jail, but use telemedicine to connect to the 4 other rural area jails. And they're present at the time of booking. They do things like crisis assessments, but they also do follow-up care with the medical providers in the jail. But in addition to that, we do a psychiatric clinic. We've had that in place for a long time in all of these areas. But the way that works is the jail navigators or medical staff or the client identifies themselves as a person who would like to receive mental health treatment or has medication when they are booked, and they are then able to be seen by our psychiatric providers to have medication treatment while they're in jail. In addition to that, there's some specialized services for veterans, for example, that we do some additional outreach to veterans that are maybe incarcerated, so that they can connect through some additional community services that are available. But those are the primary ways in which we interact with folks that are incarcerated presently.
Great. And that kind of connects to one of the other questions that we've got. So one of the 9 required services for CCBHC are services related to veterans. And so is there, or did you see a difference in how veteran services were provided in a rural area versus in a more urban area? Or is there a change in how you've provided veteran services since becoming a CCBHC?
We were serving veterans before becoming certified. We had a veteran peer coordinator, and being in a rural area, he had developed a network of other peers to help connect veterans to our services or just to veteran services in their area for benefits, things like that. Part of the certification requirements contains a sizable attestation that you'll meet certain standards for serving veterans. And we found that within the framework we had already established, we could meet those standards. So the services we could provide veterans pretty much continued through certification without major changes.
Dino, you had mentioned the focus on CQI as part of the certification process. There's a question about, can you discuss how your performance improvement processes have changed as a result of becoming a CCBHC?
Well, we have started monitoring a number of things, not only through the HEDIS measures and the medical conditions of individuals. It's helped move forward. to make sure that we have people in the right levels of care. We have tried to review a number of processes that's been put in place. That's kind of where we're at.
And Gianna, how about for Helen Farabee centers? How has your process improvement changed since becoming a CCBHC?
Well, I think because you're held to different standards at this point. And I see, can I relate it also to this question about, are your services the same as other local MHMRs, or is it just different with different certifications? Once you become a certified behavioral health clinic, you must have certain services and you must provide them in certain ways. So you must have the behavioral health part of it, you must have substance abuse, and you must do also tying in the physical health care aspect of it. So prior to that, while all centers might have said, hey, we've done a lab draw, we noticed that your blood sugar levels are a little bit off, you need to see your PCP. And that's as far as it went. Well, that doesn't cut it once you're a certified community behavioral health clinic. You have to take it steps further and do a whole lot more. So things are a little bit different once you're a CCBHC, that we are different. Our services are kind of services on steroids, that you must meet certain criteria and you have to go those steps further to tie in all those things together. And you are, in my opinion, and maybe it's because we're really proud to be a CCBHC and to be one of the first ones, that your quality of care is much higher, is much tighter. The things that you're doing is much more cohesive now, and your standards are much more than what they've ever been before. And it's a holistic approach now, and it's not as fragmented as it has been in the past. If that answers your question. And Andy, if you want to add anything, please jump in. Or Jenny.
Sounds good.
Well, thank you.
So Jenny, we're kind of coming up on our time, but I wanted to see if there were any final lessons learned that you've had so far, just as far as you are in the process for becoming a CCBHC, words that you would have for others that are considering CCBHC status or what it means in their community?
Sure. So, I think Dina, who's on the call with me, was the person here who did a lot of the work to get us down the path to become certified. And she alluded to earlier the fact that as you go through this process of becoming certified, you do a lot of policy and procedure review, which sounds kind of boring and it's not really where the excitement is. And so what I would like to say about that is we kept trying to focus our team on why we were doing this. The reason why we're doing it is because we want to improve care for our clients. We want to be able to close the loop on referrals, as Gianna mentioned, for whether it's for physical health care and things like diabetes and heart disease. And we know they take medications that often lead to side effects that can even complicate their already difficult health situations. And so becoming more responsive to that and taking more care and following up with our clients who are at high risk for some complications is really important. And it has really important impact on their lifespan and their quality of life. And so the reason why we want to do that is so important. The other thing that I would say is here at Betty Hardwick Center, we were not able to achieve an expansion grant early on. And so for us, the figuring out how to do some of these service expansions without additional resources has been a bit of a challenge, but it's not impossible to do. And so we'll continue to seek some of those opportunities, but we've been pleased with the ability for us to rethink some of the things that we do. And we have a lot of data in our system already. And so that's been a big positive for us as we've tried to change the way we look at some of those things related to care coordination, especially.
Great. I want to turn back to Melissa, because Melissa, you've been involved in certification of all 21 of the centers across the state. And you've gotten a chance to have those interviews with staff. And I just wanted to see if you had any final thoughts in terms of what you've seen across the state and things that have really stood out in terms of the work that centers, especially those in our rural areas, have done to become a CCBHC.
Yeah, so I have seen quite a few reviews. So one thing that I wanted to kind of mention is that just kind of seeing how it's evolved over the past few years, since I've been working on this since 2016. So seeing how CCBHC has evolved, and then also how centers have started to adopt the CCBHC model early and earlier. I think with Andy and Gina can attest to, it was still kind of new, so we were still trying to figure it out. And then by the time their recertification came around, they were just like, you know, we kind of got this, or we're moving, we're shaking. And then whenever it came to Betty Hardwick, who is just certified this past spring, I think, right? Spring. So they kind of already had some of those key pieces in place that they had learned from other centers that had already gone through the process. So one of the things that we've really seen and really appreciated is that the centers, especially the local mental health authorities, have really worked together to promote CCBHC across the state, and really working on language that makes sense for their communities for care coordination. I think in the rural side of things, there are often partnerships and agreements that happen informally with other organizations. And so formalizing some of those relationships have been very important for the rural folks. And so as we kind of move forward, we are seeing just additional folks that are serving rural populations, and really making sure that the folks that they do see are getting this coordinated care, even if it has to be across multiple organizations and even multiple locations that a center might run in a given area. So that's just something that we've been seeing and we're super excited about. So.
Great, thank you very much. There was a final question that I saw in terms of the list of CCBHCs. If you go to the HHSC website, you can find that list of CCBHCs, and it continues to grow as we certify those. So I would encourage folks to go and search CCBHC on our website, and you'll find all the information about CCBHCs.